Look, Soumya, are you okay?
Yes, sir. Okay. 2
Okay,
minutes.
can you make it full screen?
Yes, sir. Joined. It's not happening. Share options. Share options. Give me my files first. Sir, sorry, sir. 2 minutes, sir. Share screen. Share screen. Kada. Your entire screen. Bantu. ಇಲ್ಲ it's not show slide show. ಅದು ಬರ್ತಾ ಇಲ್ಲ. It's coming here. It's coming here now. It's photo. Show me. Presentation. Now it's came. It is coming small. Okay. Shivani video minute. How should I do full screen?
देखिए ये और सुनिए थोड़ा सा स्पेलिंग वगैरह देखने को मिली थोड़ा सा
You can put slideshow. Slideshow.
Okay,
You can
no
put
problem.
slideshow.
Sir, for some reason, she is not able to. Let us start it, sir. We've been trying for the last 15 minutes.
Sir, can you
without
see
much
that?
success.
Sir, can you see it now, sir?
Yeah, we
I can see your slides, ma'am, but it is not in the slideshow. So,
Okay, sir.
okay, let me tell you, do something. First, unshare this.
Yes, sir.
Close the PowerPoint.
Yes, sir.
You are not yet unshared. Have you unshared that?
I'm sharing it, sir. I'm doing it, sir. I unshared it, sir.
You just no, don't do anything. Just listen to what I'm trying to tell.
Yes, sir.
Go to the share screen button. Press the share screen button. What are the options you are getting?
Sir, I'm getting application window, sir.
Okay. Are you getting full screen? Desktop you are getting?
Yes, sir. Not desktop, sir. Application window, I'm getting one is PG Clinic, sir. One is presentation, one PowerPoint, sir.
You have not closed the PowerPoint then. You please close that PowerPoint. Come out of this option. Go to the desktop. Close
Okay, sir.
all the windows you have opened except Zoom.
Yes, sir. I'm closing, sir.
Okay. Now press the share button. What are you getting now?
Sir, there is only application window, sir, and your entire screen, sir.
Entire screen. Press that one.
Yes, sir.
Have you pressed it?
Yes, sir. But I'm unable to share your my entire screen, sir.
Why? What is that it is telling?
This share button is not highlighted, sir.
Okay. You come back now. Open the PowerPoint in your desktop.
Yes, sir.
Now you press the share screen mode.
Yes,
What
one
are you
minute.
getting?
Just 1 minute.
You just listen to what I'm telling. Don't try anything new. Faculty
Yes,
are waiting for so much time. I don't want them to more wait. Just listen to what I'm trying to tell.
yes, sir.
Switch on your video first.
Yes, sir.
You open the PowerPoint in your laptop.
Yes, sir.
Now press the share screen button.
Yes, sir.
What are you getting?
Sir, application window, sir.
Hmm.
With my presentation there, sir, in that
Okay,
open.
press that.
Yes, sir. Yes, sir. I opened.
Okay, don't worry about full screen. We let us start the presentation. You are able to, you know how to move the slides in this mode, right?
Uh, yes, sir. I'll just
Go to the second slide.
one. No, sir. I'm unable to move.
Have you used PowerPoint before?
Yes, sir. I've used it, sir, before, sir.
Do you have page up, page down button in your laptop keyboard?
Yes, sir. It's there, sir, but it's not working, sir.
But I can see you can move your cursor, right?
Yes, sir. I can move my cursor, sir.
Just
Yeah,
click on the second slide. On
that's
the left side, you see the red bar around the first slide, no? Just click on the second slide.
It's not happening, sir.
why you can move it, right?
Yes, sir. Get one laptop, change my wire.
Do you have any of your colleague next to you? Just get them online.
Yes, sir. Sir, I'll just give me 2 minutes. I'll just change the system, sir. To 2 minutes,
No,
sir.
this has
No,
been
no.
happening for the past 20 minutes without any success at all. You please
Yes,
get your
sir.
colleague onto the screen. I'll tell them what to do.
Yes, sir. Sanjay.
Uh, Doctor, you please take the PowerPoint into your mobile phone.
ನಿಂದ್ರಲ್ಲಿ open ಆಗಿದೆ. Oh,
First time ever we are facing this problem.
yes, sorry. ಯಾರ ಫೋನಲ್ಲಿ ಓಪನ್ ಇದೆಯಲ್ಲ I'll present in that only.
You have opened it, ma?
Yes, sir.
You please unshare
Yes,
the
sir.
screen, Dr. Swami.
Yes, sir.
Okay, Kana, you joined into the Zoom, ma? We're using the same link. You join in the phone also to the Zoom.
Yes, sir. On the phone. On the phone. I have screen share. Doctor, open that. You need to log out of there. It's coming here. It's fine. It's fine. I'll come there. It's fine. You come here. I'll find.
Just check if you are able to move the slides. Yeah, you are good to go. Please switch on your video, Dr. Swami, as well as audio. You're not able to do. The friends of Soumya, can you log in and keep your phone as her presenting phone?
Hello, sir.
Yes, ma'am.
Yes. Keep it open. Yeah, keep it open.
Ibrahim sir, thank you very much. You please
Yes,
start
sir.
your presentation, doctor. One of the faculty is helping out to share the screen. Just concentrate on the presentation. Start your presentation. Faculty, very sorry for this problem. I'm unsure what is this technology happening, and for the first time, this has been such a long delay. I apologize for that happening today, and sorry for making you all wait for the past 20 minutes for this reason.
Yes,
So
sorry.
thank you, Dr. Ibrahim sir, for taking the efforts to share the screen. So I warmly welcome all the faculty, Rajiv sir, Khanna sir, Ibrahim sir, Sridhar sir, and all the other senior faculty here. Without much ado, let us start the presentation. Dr. Soumya, please introduce yourself, your unit chief, your head of the department, and start your
Yes,
presentation.
yes, sir.
Faculty, please take over.
Yes. Sir, good evening, sir. Myself, Dr. Somadi Talikoti, sir. I'm postgraduate student from Department of General Surgery, KMCRI, Hubli, sir. I'm presenting swelling in the right side of the upper neck, sir, under the guidance of Dr. Gurshantapa Yalagachin, sir, Professor and Head, Department of General Surgery, KMCRI, Hubli, sir. Thanks. Uh, Sir, I start the presentation, sir.
Yes,
Here is a
please.
Yes, please.
Yes, sir. Sorry, sir. Here is a 60-year-old male, sir, farmer by occupation, hailing from Bammanahalli, sir. He came with complaint of swelling in the right side of the upper neck from last 3 months, sir. Patient was apparently normal 3 months back, sir. Then he developed swelling in the right side of the upper neck, which was insidious in onset and progressed from a size of 3 cross 3 centimeter to the current size of 10 cross 10 centimeters, sir. It was not associated with pain in the swelling, sir. There is no complaint of raise of temperature and night sweat, sir. There is no complaints of loss of weight, sir. No complaints of difficulty in speech and change in voice, sir. No complaints of difficulty in swallowing, sir. And there is no complaints of difficulty in breathing, sir. No complaint of nasal bleed and nasal congestion, sir. No history of chronic ulcer in the oral cavity, sir. No history of altered bowel habits, sir. No history of abdominal distension, sir. No history of ear pain, sir. No complaints of difficulty in opening mouth, sir. No history of dentures, sir. Patient is a chronic alcoholic, smoker, and tobacco chewer, sir. Uh, Past history, sir. Patient is not a known case of diabetes mellitus type 2, sir. Not a known case of hypertension and asthma, sir. No history of tuberculosis, sir. No history of previous hospital admission and surgery, sir. No history of irradiation to head and neck. Family history, sir. No history of cancer or cancer-related death in their family, sir. No history of tuberculosis in family members, sir. Personal history, sir. Patient's appetite is adequate, sir. Patient's sleep is sound, sir. Bowel and bladder habits are regular, sir. Patient is a chronic alcoholic, tobacco chewer, and smoker from last 40 years, sir. Summary of my history, sir. Here is 60-year-old male, chronic smoker, tobacco chewer, came with complaint of progressive swelling in the right side of the neck, sir. No complaints of loss of weight, sir. Evening rise of temperature and night sweat, sir. It is suggestive of uh, anatomically lymph node enlargement, sir. Uh, then pathologically, I suspect it has malignancy and or tuberculosis, sir.
Okay, Dr. Shivani. Let's go to your
Yes, sir.
first slide.
So, my sir. Yes, sir.
Sir, Ibrahim sir is handling, sir. Please permit him to. Sir is handling the PowerPoint, sir,
Yeah,
today.
Dr. Ibrahim. Let's get to your first slide, Dr. Ibrahim. Okay, that's fine. So 3 months history of swelling in the right side of neck and nothing else.
Yes, sir.
Just next
Yes, sir.
slide, please. Look, you can
Yes,
just
sir.
say that no history suggestive of tuberculosis, right?
Yes, sir. Yes,
Or
sir.
no history suggestive of any involvement of the aerodigestive. You can't list out the whole list. There's this, you missed hemoptysis, you can miss, there's a lot of things you can miss, no?
Yes, sir.
For each
Understood,
of
sir.
them. Just say upper aerodigestive system, and that covers most of it. And then the questions will be asked. right? Okay.
Okay, sir.
So you can't give a whole list here, right? In 3 months,
Yes, sir.
it's progressed from 3 to into 10 centimeters, right?
Yes, sir.
Next slide, please. Okay, we've got all this now here. Why do you take history of altered bowel habits and abdominal distension?
Sir, if there is a, as I'm suspecting it has a lymph node mass, sir.
Mhm.
It is a malignancy as I'm suspecting, sir. Patient is 60-year-old and it has rapidly progressed,
Mhm.
sir. And the patient is
Right.
smoker, sir. So there is
Mhm.
less than 2% chance of GI malignancies presenting as a lateral neck swelling, sir. So I wanted to rule that out, sir. And in lymphoma, primary lymphoma, if has a malignancy, sir, they will be having organomegaly, sir.
Okay, that's fine. What about
Yes, sir.
history of ear pain?
History of history of, sir.
Ear pain, ear.
Ear pain, sir. So ear pain, I wanted to rule out if nasopharyngeal carcinoma is involved, sir. If nasopharyngeal carcinoma is involved, there will be the blockade of eustachian tube, sir, which leads to ear pain, sir. Or if involvement of the glossopharyngeal nerve, sir, direct involvement through the mass in the lateral neck swelling.
Okay. Next slide, please. You don't say chronic alcoholic, it's just a chronic consumption of alcohol. Alcoholic means that he becomes dependent on it. Okay. What about any other swelling in the neck? What about a thyroid swelling? Does he have any thyroid swelling? Any other swelling in the neck? Have you taken history for that?
Okay, sir. Understood.
Okay, you got to take that. Okay, past history, not case of diabetes. Make it a medical history. You should put it as a medical history, right? Not as past history. Okay, next
Okay, sir.
slide, please. Which cancers are you looking for in family history?
Sir, if lymphoma, sir, if any P53 mutation involved malignancy, sir, like in CA lungs, sir, they will be having P53 mutation, sir, because of which there can be familial, sir.
Okay. What about colonic cancers, GI cancers?
Yes, sir, they can be
We'll come to
malignancy,
that.
sir.
We'll come to that later. Okay, next slide, please. Okay, next slide. So, what are the points in favor of malignancy?
Sir, one is
And
patient is 60-year-old, sir. The
Mhm,
patient is chronic smoker, sir, which accelerate any malignancy, sir. Then
mhm.
it is a painless progressive swelling, sir. It has
You've missed
progressed
alcohol
from
here. Alcohol is also sorry. Alcohol is also important, but you have missed this in your summary.
yes, sir.
Chronic consumption of alcohol is also important, which you missed, right?
Okay, sir.
Okay.
Okay.
And what about tuberculosis?
Sir, tuberculosis have asked him about the evening rise of temperature and night sweat, sir. It is not this, sir. But has we know, so all the lateral neck swelling will not present as TB lymphadenitis will not present as evening rise of temperature and night sweat, sir. But as it is common swelling, sir, so I have to rule that out, sir. Tuberculosis.
Uh, what about
Soumya, why do you
lymphomas?
think it is lymph node mass with the history?
So most common swelling in the lateral side of the neck is a lymph node mass, sir, and he's a 60-year-old male, sir. I'm suspecting it in terms of malignancy, sir. So I thought it has a lymph node mass, sir.
This is a site, if you tell. So it is the most common site for lymph node swelling. Lymph
Yes,
node
sir.
presenters. What are the points in favor of malignancy?
Sir, he's a 60-year-old male, sir. He's a chronic smoker and tobacco chewer, sir. And is a painless progressive swelling, sir. It has progressed in 3 months from a size of 3 cross 3 centimeter to the size of 10 cross 10 centimeters, sir.
So are there any symptoms of primary?
Sir, there are no symptoms of primary, sir. As patient is chronic smoker and tobacco chewer, sir, I'm suspecting in terms of oropharynx and nasopharynx, sir. And
But there are no symptoms.
no symptoms, yes, sir. No symptoms of no primary symptoms.
Is there any history which is against malignancy?
There's no loss of weight, sir, which is against malignancy, sir. But most of the cancers of the upper aerodigestive tract, sir, they'll not present with loss of weight, sir. Here, loss of weight will be mainly because patient is unable to eat, sir, because of nutritional deficiency, sir, because of like CA tongue, sir, CA oral buccal mucosa, sir.
Okay, good.
Yes.
So shall we proceed with examination, sir?
Examination,
Go
please.
ahead. Go ahead.
Soumya, if it is a upper neck swelling and the lower neck swelling is there, and you
Yes,
think
sir.
it's a malignant pathology is there, what is your
Yes, sir.
mind? Yeah, whether it is upper neck pathology or the lower neck pathology.
Sir, if it is an upper neck pathology, sir, I'll suspect more in terms of nasopharynx, oropharynx, and hypopharynx, sir. If it is in lower neck pathology, sir, where group lymph nodes like 4, 6 are involved, sir, at that time I'll suspect it has papillary carcinoma of the thyroid, sir. Any CA lungs, sir. On the bronchogenic carcinoma, sir.
Okay.
If it's
There is
an
no other swelling in the neck apart from that in this
no,
patient?
sir, there is no other swelling apart from this, sir.
Okay.
So
Dr. Shiva,
you have mentioned as lymph nodal enlargement. Have you asked any history of lymph nodal enlargement in other group of lymph nodes? What history?
No, sir. Sir, I've asked, sir, if any enlargement in the axilla, sir, in the inguinal region, sir, enlargement of the lymph node, sir, he's not having, sir.
Where have you mentioned it? The
Okay,
history.
sir.
Have you ever mentioned that thing? That is not mentioned, right? Presenting
Yes,
illness.
sir, it's not. Yes, sir.
Lot of negative histories. Your
Yes, sir.
organ lymph node, right? So lymph node most of the time it comes in groups. So you have to mention
Yes, sir.
that as a history.
Yes, sir, understood.
Another thing is lymph nodal enlargement can come as recurrent. So in the past history, you have to mention there is no history of previous enlargement, similar enlargement.
Okay. In the past, yes, sir.
So these tools are very important.
Yes, sir.
Sir, shall we proceed with the examination, sir?
yes, please, examination.
Yeah, please go ahead.
Sir, examination, sir. Here is a well-built, moderately nourished old man, sir. Patient is conscious and cooperative, sir. There is no signs of pallor, icterus, cyanosis, clubbing, and pedal edema, sir. Patient ECOG score is 0, sir. Patient vitals are stable, sir. BP is 130 by 90 millimeters of mercury, sir. Pulse rate is 78 beats per minute, sir. Respiratory rate is 20 cycles per minute, sir. SpO2 is 98% at room A, sir. On local examination, sir, first examination of the neck I want to do, sir. On inspection, sir, solitary swelling present in the right upper and middle one-third of the neck, sir, present in the entire triangle, measuring 9 to 7 centimeters, sir, with well-defined borders, smooth, appears to have smooth surface, sir. It is non-pulsatile, sir. Skin stretched, sir. Platysma sign is present, sir. Swelling is extending anterior to anterior border of the sternocleidomastoid muscles.
So in inspection, you have to mention the position of the patient. So what is the position of the patient here? Sitting,
On
standing?
palpation, sir.
No.
All inspector findings are confirmed.
No. What is the position of the patient during inspection? How is the patient? He's lying down, supine, prone, lateral position, sitting. How do you examine a neck? Are you there?
Hello, sir.
Are you there?
Yes, I'm here, sir.
Yeah. I just wanted to know what is the position of the patient during the local examination inspection. What is the position of the patient?
Sir, patient examined in in sitting, sir, on a stool, sir, with a straight. First, I examined with the straight face, sir. Then I examined with an extended neck, sir.
So is that important in neck?
Neutral position, sir.
Yeah, is that important in neck examination? What is the ideal position of neck examination? Supine or sitting, which is better?
Sir, sitting position, sir.
So that has to be mentioned. Okay. Yeah.
Yes, sir.
So that has to be mentioned as the first point. Then you can go ahead. Yeah.
Yes, sir, understood, sir. So on palpation, sir, all in slides.
Is there any swelling you have mentioned as non-pulsatile?
Yes, sir. It is non-pulsatile swelling, sir.
when I am seeing the picture, the patient appears very thin.
Yes, sir. Patient is yes, sir. Not very thin, sir. Is moderately built.
Okay, neck
Well
appears.
built and
Can you
yes, sir.
can you see the normal neck pulsations on the opposite side?
No, sir. We can't see the normal pulsation, sir.
No carotid pulsation is seen.
No, sir.
No, IJ.
Could we ask her to finish the examination before we ask questions?
Yes, sir. We'll go ahead.
Because it throws us off track. Yeah, please.
Yes, sir. Sorry, sir. On palpation, sir. All inspected findings are confirmed, sir. Solitary swelling present in the right anterior triangle in the upper and middle one-third of the neck, sir. Measuring of about 9 to 7 centimeters, sir. Extent is superiorly 1 centimeter below the angle of the mandible, sir. Inferiorly 3 centimeter above the clavicle, sir. Medially 2.5 centimeter lateral to midline, sir. Laterally 3 centimeter below the mastoid, sir. It is having nodular surface, sir, with a well-defined border, sir, which is hard in consistency, sir. Skin is pinchable over the swelling, sir. Swelling is fixed, sir. There is no change in swelling on putting sternocleidomastoid on contraction, sir. On clinical examination, trachea deviated to left side, sir. Right side carotid artery is not palpable, sir. Bilateral superficial temporal arteries are palpable, sir. There is no other swelling in the neck, axilla, and inguinal region, sir. This is the diagram, sir. Next, examination of the oral cavity, sir. This is a video of the patient.
Come speak. Dr. Shivaregli.
The examination of the oral cavity, sir. On inspection, sir. Mouth opening is adequate, sir. Poor oral hygiene, sir. Dental caries are present, sir. Lips, gingival labial fold, gingival buccal fold, floor of the mouth, hard palate, soft palate, and retromandibular trigone, sir, appears normal, sir. Tonsil, there is no enlargement of the tonsil, sir. No growth seen in the tonsil, sir. Tonsils are not pushed medially, sir. There is no deviation of uvula, sir. Palatal movements are normal, sir. On palpation, sir, no induration present at the anterior and posterior part of the tongue, sir. No induration present in the retromandibular trigone, sir. No induration at the hard and soft palate, sir. On systemic examination, sir, respiratory system, sir, bilateral non-vesicular breath sounds present, sir. There are no added sounds, sir. Cardiovascular system, sir, S1, S2 heard, sir. There is no murmur, sir. Per abdomen examination, sir, soft, sir, non-tender, sir. There is no organomegaly, sir. Bowel sounds are present, sir. Summary, sir. Here is a 60-year-old male, sir, who is chronic smoker, tobacco chewer, with complaint of painless progressive swelling in the right side of the neck, sir. On examination, a solitary fixed swelling with nodular surface and hard in consistency, sir, which is suggestive of lymph node enlargement, sir, with malignant etiology, sir. Query secondaries in the neck, sir.
Okay.
Soumya,
Yes.
why do
Let's
you say
continue.
it is only in the anterior triangle?
So it is extending into anterior triangle, sir, and crossing in front of the anterior part of the sternocleidomastoid, sir, and it is extending into the posterior triangle also, sir.
But you are only mentioning it in the anterior triangle. This is also occupying the posterior triangle also.
Yes, sir, posterior triangle also.
Mhm. And what is that nodule over the swelling? You have not described that.
Sir,
There is a
it's
small
a
nodule is there over the swelling. Yeah.
yes, it appears to be like a sebaceous cyst, sir. Sir.
Are you sure
Swelling.
about that?
Yes,
Why do you
swelling.
say it is sebaceous?
So
Why do you say it is
swelling.
sebaceous?
So the swelling is having a punctum. It is present to the present to the skin, sir. In the subcutaneous plane, it is there, sir. And is measuring of about 2 cross 1 centimeter, sir.
If I say it is a nodule which is there, which is a melanoma, okay, just for thinking about that, what is the
Yes.
objection to that? It's
So
a
it,
blackish nodule which is there over that.
so it can be a blackish. It can be involvement of the skin also, sir.
No, Dr. Shivani. Was the
Yes, sir.
swelling, this nodule present before the swelling, or it has appeared after the swelling or with the swelling?
So it is present before only, sir, from the long history, sir.
So
Does
you
he
say
give that
that.
history? Yeah, tell that if it is there, history is there.
Yes, sir.
Yeah, because if you find a blackish nodule, you have to think of something else, you know? But if it is there for a very long time, then it is different.
You got to mention that, no? In your
Yes, sir.
history and your examination,
Yes, sir.
right? You've thrown everyone out of context here.
Right.
Okay, so let's go to examination.
Yes, sir.
Okay, non-pulsatile. Is there any cough impulse? Dr. Shivani, are you there? Hello? I think she's frozen.
No, sir. There is no cough impulse, sir.
Why is that
No,
important?
sir. There is no cough impulse, sir.
No, why is that important? Why is that important?
Sir, if laryngocele is there, sir, which you'll be having in the lateral side of the neck, sir, in the upper part of the neck, sir, they'll be having a cough impulse, sir. But he has patient is 60-year-old, sir, and it is hard and fixed, sir. Sir.
That's a palpation, no? We are talking about inspection,
Yes,
right?
sir. Sir.
And don't say 60 years old. You've made all of us here old now.
Yes, sir.
Yeah. Next slide, please.
Dr. Soumya, you mentioned platysma sign is positive.
Yes, sir.
Can you tell me what is it?
Sir, the swelling is.
What does it denote?
So it denotes that it is an extended into the platysma, sir, because of which the platysma, upper part of the platysma is stretched, sir. So the lower part of the lower part of the platysma is
You're there?
But Shivani, just close your video and
skin
just keep the audio
folds
on.
underneath, sir. Which
I think she has some connection problem.
I can hear,
Yeah,
sir. I can hear. Sir.
Yeah.
Go ahead,
Okay.
go ahead.
Okay. Nodular surface, well-defined border, hard inconsistency. All through, or
Yes,
is
sir.
it variegated? It's all
No,
through.
sir.
Okay, next slide, please.
All throughout it is hard in consistency, sir, with nodular
Yeah.
surface, sir.
Okay, this line, all inspectory findings are confirmed. Just do away with it. You can't confirm color of the skin with on palpation, right? So
Yes,
don't
sir.
do that.
Okay.
It conveys nothing. It conveys nothing.
Yes, sir.
Right. Next slide, please.
Yes.
Skin pinchable. Why do you do that?
So I wanted to know the extranodal extension, sir, if skin is involved or not, sir. But skin is pinchable, sir.
So is that a good way of finding out whether the skin is involved? Suppose the skin is involved
Yes,
only in one area. You can pinch it from the other areas. So if you move the skin over the swelling and
gliding
the
of
skin,
the skin over the swelling is also present, sir.
right? So that should be there. Right?
Yes, sir.
The trachea is deviated to the left side. You
Yes, sir.
think this
Clinically, taken.
cervical lymph nodes will push the trachea to one side. Where is the trachea
Sir,
situated? Where are these lymph nodes situated?
sir, it is situated in the lymph node is situated in the upper part of the neck, upper and middle part of the neck, sir. As it is large mass, sir, it can deviate the trachea, sir.
No. Okay. We are talking of this, but what are the depth? This lymph node is fixed to what? You said the swelling is fixed. Fixed to what?
So fixed to sternocleidomastoid, sir. And
Okay.
Yes, sir.
And right. And the trachea is above the sternocleidomastoid or below the sternocleidomastoid?
Sir, medial to sternocleidomastoid, sir.
No, I mean in depth. Look, the trachea is right behind a
Yes,
large lymph node. Unless they are paratracheal lymph nodes, they will not
yes, sir.
push the trachea to one side.
Yes,
So
sir.
how did you know that the trachea is shifted to the left side?
Sir,
How do you test for it?
clinically, sir, on doing the trail sign, sir, the trachea is deviated towards the left side, sir.
So what is trail sign? Is it inspectory finding or palpatory finding?
Palpatory finding, sir.
No, it's an inspectory finding. Trail sign is that there's a prominence of the sternocleidomastoid when the trachea is deviated to that side, isn't it?
Okay. Okay.
Any other way of finding whether the trachea is central or deviated?
So
You
by
can do an
palpation,
auscultation. Yeah, you can do a three-finger palpation, or you can do
yes,
an
sir.
auscultation.
Yes, a three-finger palpation test only, sir. It is deviated towards the left side, sir. There is more space in the right side, sir.
Okay, okay, okay. Next slide. Next, please. Next, next, next. Okay, oral cavity, nothing there. Palpation, nothing.
Yes,
Look, you can't palpate the soft palate. How do
sir.
you test
Check.
just for Indian soft palate, hard palate? You can't palpate it. He's going to bite off your finger. Don't do it. Okay.
Yes,
Posterior part of you can't put your finger right into his gullet here.
yes,
What about his eyes? Have you tested his eyes?
yes, sir. Eyes are normal, sir. Bilateral eyes are normal, sir.
What are you looking for? What about Horner's?
So, there's no, so there's no Horner symptoms, sir. There's no signs of sympathetic chain involvement, sir.
That's what I'm saying, sir. You got to mention it.
Yes, sir.
You got to mention it, right?
Yes, sir.
Right? Okay. So, anyone?
Did you
Anyone?
examine
Or
any cranial nerves?
So cranial nerves I've examined for the glossopharyngeal nerve, sir, for the vagus nerve, sir, for the spinal accessory nerve, sir, and for the trigeminal nerve, sir. There is no involvement, sir.
Did you mention that in your examination? I don't think you have mentioned. So,
No, sir. Not mentioned, sir, but examined. Sir.
So what is the most commonest cranial nerve to get involved in such type of tumors or swelling? Upper
Sir,
neck.
suspecting spinal accessory nerve involvement, sir, which supplies trapezius and sternocleidomastoid, sir.
So how do you tested it and where have you
By
mentioned?
shrugging of the shoulders, sir, against the resistance, sir.
Okay. So have you mentioned that anywhere in the local examination or general examination?
No, sir, not mentioned, sir. They're normal, I didn't mention.
look, Dr. Shivani, you got to, there are
Yes,
lots
sir.
of things which are missing in your history, right? You say,
Yes,
I've
sir.
done it, but I've not mentioned it. There's no mention of Pankos syndrome, right? There's no mention
Yes,
of
sir.
Horner's. There's no mention of the limb, of the examination of the chest, the breast. Of male breast can also present as cervical lymph nodes, can't they?
Yes, sir. They can.
Right. So
Yes,
your history and examination. Look, this is a clinically unknown primary, isn't it?
yes, sir.
So you got
Clinically,
to
yes,
make
sir.
yeah. So you got to make a great effort to find out where the primary is, and that
Yes, sir.
takes your detailed history and examination is the one which is going to bring out all the facts, right?
Yes, sir.
So you got to be
You examine the
very
testes
examine
of
this
this
man.
patient?
Yes, sir.
Have you examined the testes of this patient or not?
So examine, sir. They both are in place in the scrotum, sir.
No, it will be in the place only. But where have you mentioned and what is the size? Any enlargement? Any change in consistency?
No, sir.
Why is it important? Elderly male, lymph nodal enlargement or neck involvement, So what is the most commonest cause? What
So
you can
that's
expect is
so when undescended testes which can present as a
at 60
malignancy.
years. At 60 years.
No, sir.
Carcinoma testes, okay? Testicular tumors.
Yes,
Okay,
yes, sir.
Dr. Shivani, I'll just
Yeah.
give you a piece of advice. Look,
Yes, sir.
your examination has to be very thorough,
Yes,
top
sir.
to
Understood.
bottom,
Yes,
right?
sir.
Top to bottom. It can be a melanoma somewhere, which you've made. So you have to examine this patient very careful. This case tests your skill for history and examination. Maximum
Yes, sir.
tests, right?
Yes, sir.
So yeah, go on.
Sir, USG of the
Now let's compare your probable diagnosis.
yes, sir. Okay, sir. Sir, problem. Clinically, I'm suggesting it has sir lymph node enlargement, sir, with malignant etiology, sir, with secondaries in the neck, sir. Has neck swelling, sir. There is chance of having primary malignancy also, sir, has secondary malignancy also, sir. But presentation of the lateral neck swelling with secondary malignancy is most common, sir. So I'm suspecting it has a secondaries in the neck, sir.
So this
Primary
is very.
malignancy.
So your
Yes, sir.
diagnosis would be a clinically unknown primary. Clinically unknown primary means second is with the clinical. Your
Yes, sir.
clinical examination has not thrown up any trace of
Primary
primary,
state. Yes, sir.
right?
Yes, sir.
So what is the difference between a clinical unknown primary and an occult primary?
Sir, occult primary are those which we can't examine, sir, like like fossa of Rosenmuller,
Very
sir,
good,
like
very good.
piriform sinus, sir,
So
like
if you
valleculis.
okay, that's fine, that's fine. So
Yes, sir.
if by investigation you can come up with a primary, then it becomes a an occult primary, okay?
Yes,
And in
sir.
spite of doing everything, and you can't
Yes,
find any primary,
yes,
then
sir.
it becomes
Unknown
unknown
primary.
primary.
Yes, sir. Understood.
Yeah. So
Okay,
how do you manage
Soumya,
this
what
patient?
are the cancers other than head and neck which will produce this kind of secondaries?
So the GI malignancy, sir, colorectal malignancy, sir, renal cell carcinoma, sir, which is very rare, sir, and minor salivary gland tumors, sir, and CA lung, sir, bronchogenic carcinoma, sir.
So, Dr. Shivani, you've got a whole list. Now you have to take history of all of them. You've not taken history of hematuria. You've not taken history of any genitourinary symptoms, right? You've
Yes, sir.
you've you've taken a cursory history of GI tract, right? So these are the
Yes, sir.
deficiencies which you have to clear up,
Yes, sir.
right?
To be mentioned. Yes.
When you say it is a cup, CUP,
Yes, sir.
yeah, is it only after the history examination or it is after the investigations, chair?
Sir, on history level also we can tell, sir, but we can't be sure, sir, until we do the investigation and tell. Like occult primary has to be ruled out, sir.
The majority of the time it is after the thorough investigations has been done, then you
Yes,
label
sir.
that as. And
Yes,
which
sir.
is the commonest carcinoma in the CUP?
Sir, upper aerodigestive carcinoma, sir.
Which type of the histologically, which type of the carcinomas are more common?
Sir, as if you consider it as a CUP, sir, there adenocarcinoma is common, sir. But if we consider as lateral neck swelling, sir, presenting as secondaries in the neck with unknown primary, sir, squamous cell carcinoma is common, sir.
Overall, adenocarcinoma is more common. But if
Yes,
it
sir.
in the lateral neck is there, yes, it is a squamous cell
Squamous cell
carcinoma.
carcinoma, sir.
Right. Yeah. So you want to keep any differential diagnosis
Uh, no, sir.
rather than just saying it is the unknown primary?
Sir, I don't want to keep a differential answer
If I say
because
it is arising from the thyroid,
what, sir?
it
I
is
can.
arising from the thyroid.
Sir, no, sir. Thyroid
It is
is not
anaplastic
cultivated, sir.
carcinoma arising. Hmm?
So, but
Right. Trachea is shifted to the left side.
yes, sir.
Carotids are not palpable.
Yes, sir.
and there is swelling in the upper part of the thyroid region.
Sir, but thyroid if swelling is there, sir, it will be present in the lower neck, sir, and lower neck, lower lymph nodes will be involved, sir. If lymph nodes are involved, it will be in the lower
I'm not
part,
saying
sir.
it is. I do not say it is the lymph nodes. I say it is a primary tumor arising from the thyroid, anaplastic carcinoma arising
So
from
it
the.
does not move with deglutition, sir.
It is a fixed tumor.
It's a midline swelling, sir. It is a lateral swelling, sir.
So you don't have the thyroid in that area. It is only in the midline you get the thyroid swelling. No, that is the possibility.
Okay, sir.
You
Understood.
just cannot say that it is only the lymph nodes primary which is there or the secondary which is there. And so you have to
Yes.
think about
Okay,
that.
what is
Yeah.
lateral aberrant thyroid then, Shivani? What is a lateral aberrant thyroid?
So it's enlarged. So it's a papillary carcinoma of the thyroid. So involvement of the primary.
You are there, Dr. Soumya?
Yeah,
Sir,
go on, please.
sir, it's a papillary carcinoma of the thyroid, sir, with the spread to the lymph nodes, sir, lateral lymph nodes, sir. Mainly group 4 lymph nodes, sir.
So the thyroid may be normal, right? But it has metastasized to the lymph nodes. Do you get me? Hello?
Patient will be having papillary carcinoma of the thyroid, sir.
Right. So this is a metastatic papillary carcinoma of the thyroid. So that can also be one of your differentials. Okay.
Yes, sir. Yes, sir.
Okay. So why do you think the primary cannot be seen?
Sir, the sir, or it can be subinvolution or the regression of the primary site, sir. If in history the patient might have underwent for any excision, sir, like for the any melanoma excision, sir.
No, I'm talking in this case. Why do you think the primary cannot be seen? What are the causes?
In his
Dr. Shivani, I think you should. Yeah, just do away with your video. I think it's interfering with.
yes, sir, it's I can hear now, sir.
Did you get sir's question?
Yeah.
Shivani?
Yes, sir. I got, sir.
Then answer.
Sir, either primary will be very small, sir, to be
So what are the
visually
reasons why
seen.
the primary cannot be seen?
Sir,
So they're very small
primary.
but aggressive. Could be very aggressive but small.
Yes, sir. Very small, sir, to be visual. Sir. Or it can be, it has appeared, sir, it can underwent regression, sir, spontaneous regression of the primary tumor, sir.
Very good. Very good.
Subinvolution.
Or it could be in some area where we're not being able to detect it.
Yes, sir.
Professor Abhay Dalvi raised his hand, sir. Professor
Sir,
Dalvi.
can I get the question again, sir?
Yes, please. No. Okay, Dr. Shivani, how do you manage
Yes,
this
sir.
patient now then?
Sir, I want to get the investigations done, sir. First, I want to get the USG of the patient, sir, which is reported as two irregular heterogeneous solid mass lesions, sir, noted in the right lateral neck, measuring of about 3.9 cross 2.1 cross 3.7 centimeters, sir, and 3.6 cross 1.7 cross 3.2 centimeters, sir, with minimal internal vascularity, sir.
Okay, then?
As this investigation was, next I got done the FNC of the swelling, sir. The smear study shows, sir, the cells are arranged in the clusters, sir, groups, sir, acini and single, sir. Cells are moderately pleomorphic, sir, with hyperchromatic nucleus, sir, coarse chromatin, sir, and conspicuous nucleus, sir, with moderate amount of cytoplasm, sir. Background shows hemorrhage and lymphocytes, sir. According to FNAC, sir, it is reported as deposits of poorly differentiated carcinoma, sir.
Okay. So can you do an open biopsy here?
Sir, I don't want to do the open biopsy, sir, as it can cause extranodal extension of the tumor, sir, seedling of the tumor, sir, into the skin, sir. Patient can have a fungating growth, sir, because of when we do the open biopsy, sir.
No, more important is that when you have to do a neck dissection, this biopsy will lead to distortion of the planes.
Yes, sir, and distortion of the brain. Yes.
Okay, so you've done a FNAC. Now what? Now what?
So I want to get the CCT of the head and neck, sir, to look for any primary which can be which we can get through the CCT, sir.
Okay, do you
Sir,
have the CT report?
yes, sir. CCT is reported as a well-defined elongated lesion, sir, measuring of about 6.8 cross 3.9 cross 6.2 centimeters, sir, with heterogeneous enhancing, sir, with few areas of non-enhancement suggestive of necrosis, sir. Uh, with the displacement of right sternocleidomastoid laterally, sir, medially the lesion is closely abutting the right lobe of thyroid, sir. It is in flush with greater corona of the hyoid bone, sir, with encasing common carotid artery with compression of the lumen, however, shows normal opacification, sir.
Okay. So, what do you mean by encasement and abutment?
The encasing means the tumor is encased here. Tumor is encased the carotid artery 360 degrees, sir, but it has not breached the carotid artery, sir.
Okay.
Only the lumen is narrowed, sir, but there's no significant narrowing is not
So,
there.
so does the CT say that your trachea is deviated?
Sir, according to CT, trachea is not deviated, sir. Clinically, it was deviated, sir.
No, it cannot be. That's what I'm trying to say.
Yes, sir. Understood.
I find it very difficult to accept that the trachea would be deviated. Okay, as you can see the lump here, the trachea is almost central. Okay. Uh, what about any other investigation?
Sir, patient has got the FDG PET done, sir.
No.
Yes, sir.
Any other endoscopy? What is triple endoscopy?
Sir, endoscopy, triple endoscopy is done, sir. It's in the
I'm
previous
sorry,
slide,
pan
sir.
endoscopy.
Yes, sir. Pan endoscopy, sir. Laryngoscopy was done,
You
sir.
get a PET scan before. Sorry, Dr. Shivan. You get a PET scan before a pan endoscopy.
No, sir. I want to get pan endoscopy first, sir. Then, if I on pan endoscopy also we didn't find any primary, sir. On CCT head and neck also, if I didn't find any primary, sir, then I want to get the PET scan, sir. Otherwise, I don't want to get
What
the
do you
PET
mean?
scans.
What do you mean by pan endoscopy?
So pan endoscopy is laryngoscopy, sir. Bronchoscopy, sir. Endoscopy, sir.
Endoscopy? They're all
Endoscopy and
endoscopy.
nasopharyngoscopy, sir.
Okay, so you had a nasopharyngoscopy, you have got a laryngoscopy,
Yes, sir.
you have a esophagoscopy,
Yes, sir.
and a bronchoscopy,
Yes, sir.
right?
Yes, sir. Bronchoscopy
So
is
you've
not
done that,
done,
and
sir,
then
but rest all the other endoscopies were done, sir. They're normal, sir. Bronchoscopy only
okay,
alone is not done, sir.
okay. So with this pan endoscopy, what do you have to do?
Sir, look for the occult area, sir, like for the valleculae, sir.
What
And
is surveillance biopsy? Okay, let me ask you directly. What is surveillance biopsy?
what, sir? What is?
Surveillance biopsy.
So surveillance biopsies where we take the biopsies where most common occult areas will be present, sir. But now, which we used to do previously, sir. But now we don't follow that, sir.
Says who? Who said that you don't take a biopsy from there? No, you tell me. I mean, I can stand corrected. Okay, what are the areas where you have to look for, take these biopsies from?
So from the tonsil, sir. From the fossa prosumna, sir, in the post-cricoid region, sir.
Fossa of Rosenmuller, then
Tonsil, sir.
tonsillar bed, then
Yes, sir. And from the post-cricoid region, sir.
Post cricoid.
Yes, sir.
Okay.
Base
What
of
do you
the
mean
tongue,
post
sir.
cricoid?
Posterior 1/3 of the tongue, sir.
Okay. Posterior third of the tongue. Then base of the tongue.
Yes,
Then
sir. At the subglottic area, sir.
subglottic larynx. Then
Oh, oh.
you're missing one side. Lateral wall of the pharynx.
Yes, sir. Lateral of the pharynx.
Okay.
Now, here the
So was
cytology
this done?
is the malignancy, but you are not sure still it is a squamous or
Yes, sir.
adenocarcinoma.
I'm not sure as a squamous or adenocarcinoma, sir. It is a purely differentiated carcinoma, sir.
So rather than going for the open biopsy, can we go for a core needle biopsy here? USG guided core needle biopsy to confirm all these things before we go for the
Yes,
other
sir.
investigations?
Yes, sir. Core needle biopsy, true cut biopsy can be done, sir. Yes, sir. To get the IHC report, sir, and for the tissue diagnosis, sir, whether it can to know whether it is an adenocarcinoma or the squamous cell carcinoma, sir.
So
Okay, Dr.
you have to
Shivani.
go.
Suppose, sorry, sir.
Yeah,
Yes,
please
sir.
carry on. Please carry on. Yeah.
Suppose this was an adenocarcinoma.
Yes,
How
sir.
how would that change your management? And suppose it was a
Sir,
squamous cell carcinoma.
if it gets reported as adenocarcinoma, sir, which are chemosensitive tumors, sir. If it is if it is reported as squamous cell carcinoma, sir, which are radiosensitive tumors, sir.
No, hang on. Look, this whole case is all about trying to find out the primary, right?
Yes, sir.
If you have to make all efforts. If you can't find the primary, then you have to go in
Manage.
for it, right? So if it's an
Yes.
adenocarcinoma,
Sir,
where
if
will you
it's an
start looking for?
adenocarcinoma, sir, I will be suspecting, sir, first papillary carcinoma of the thyroid, sir, or the minor salivary gland tumor, sir, or the CA lung, sir.
Right. So you have to look for the primaries below the clavicle,
Yes, sir, below the clavicle, sir. Yes, sir.
right? So it
Yes,
can be
sir.
can be in the prostate, can be in the testes, it can be in the stomach, it can be in the breast, it can be in the GI tract, it can be in the kidneys, right?
Yes, sir. Yes, sir.
So if your cervical lymph node is in the upper half
Yes,
and
sir.
they are usually squamous, you look for head neck lesion.
Yes, sir.
If you have the lymph nodes in the lower half and it's
Yes, sir.
adeno, you got to look at the primaries below the
It's at the
clavicle.
infraclavicular. Yes, sir.
So anyone.
Yes, sir.
Okay. So now how do you manage?
Sir, I want to get the biopsy done, sir. Based on the IHC, the further management will be done, sir.
Go on.
As we didn't got, sir, as we didn't get the primary in the CT head and neck, sir, patient got the FDG PET CT scan done, sir. There was a hypermetabolic FDG avid right cervical level, sir, 2, 3, 4, and supraclavicular lymph node, sir, and FDG avid deep pectoral lymph node, sir. Only one lymph node was FDG avid, sir, and there was no evidence of FDG avid lesions anywhere in the whole body scan, sir.
Okay. So now what do you do?
What is the SUV value, in the cervical node and the pectoral node? Any mention about the SUV value in the PET scan?
Yes, sir.
Can you just elaborate on that?
Yes,
Do
sir.
you have-
2 minutes. I have, sir.
Yeah, what is meant by SUV?
So is the percentage of uptake, sir. The SUV value for the cervical was 14.2, sir. The SUV value for the pectoral was 18.6, sir.
What is the size of the pectoral node?
So size of the pectoral node is 1.3 centimeters, sir.
Okay. So in the axillary palpation, you are not able to palpate it.
Not able to palpate, sir.
Okay. Okay, go ahead. Go ahead.
Yes, sir.
In this case, what IHC markers we will look for?
Sir, as it is a poorly differentiated carcinoma, sir, I need to look for many IHC markers, sir, like CD45, sir, CK5 and 7, sir, CK4, 6, sir, TGF factor, sir.
Is it done for this patient?
No, sir, it's not yet done, sir.
Okay, go ahead. Regarding management.
Sir, if the IHC marker, sir, if it comes as a if IHC marker comes as a squamous cell carcinoma and adenocarcinoma, sir, based on that, I want to treat it, sir.
So what will you do if it is adenocarcinoma? What will you do if it is squamous cell carcinoma in this patient?
Sir, if it is an adenocarcinoma, sir, has tumor is fixed now, sir, and it is more than 6 centimeters, sir. Sir, I want to get has adenocarcinomas are chemosensitive, sir. I want to give the chemotherapy first, sir.
Then, so you want to give chemo radiation?
Sir, with the chemotherapy, cisplatin and paclitaxel, sir, if it responds well, sir, I want to get the repeat scan done, sir. If a repeat scan is also favorable, sir, we can give radiotherapy and chemotherapy both, sir.
The squamous?
So if it is a squamous cell carcinoma, sir, which has it is fixed, sir, and primary we didn't found, sir, we can't operate on the patient, sir. So I want to go ahead with a radiotherapy, sir, which is it is a radiosensitive tumor, sir.
Okay.
So what are the points here in the history wise and in the clinical examination to tell that this is an inoperable tumor?
Sir, clinically it is 10 cross 10 centimeters, sir, and it is hard in consistency, sir, and it is fixed, sir, not mobile, sir. And platysma sign is present, sir. And on CT wise, it is abduct 360-degree complete encasement of the carotid artery is there, sir.
So of all the findings, which is the single most important thing which avoids surgery?
Sir,
Which tells-
fixity of the fixity, sir, involvement of the encasement of the common carotid artery, sir.
Now tell one thing, either the fixity or encasement, which is important.
Encasement of the common carotid artery, sir.
So you mentioned about the lesion in the upper neck. Okay. So
Yes, sir.
what carotid you will get in upper neck? It is a common carotid or internal carotid or external carotid. Which one will get it there?
The common carotid, sir.
So where is the common carotid bifurcation?
Sir, at the level of the so at the level of the thyroid cartilage, sir.
Upper border, lower border?
Upper border of the thyroid cartilage, sir.
So upper border. So you think it is in the bifurcation? The tumor is encasing the bifurcation?
Uh,
Or
both
common?
by anatomically, if we say, sir, it is at the bifurcation, sir. But on CT scan, it is involving the common carotid artery also, sir.
No, the encasement is in the common carotid or external carotid. Where?
It's in the common carotid, sir. In the CCT head and neck, sir.
Common carotid. Okay.
Yes, sir.
So if it is in the common carotid, there is already a compression of internal carotid also. There is less blood flow. So any history of
No, sir,
transient
he's not having history of syncopal attacks, sir.
that has to be mentioned. That is very important. Okay.
Yes, sir.
Transient ischemic attacks has to be mentioned.
Yes,
And
sir.
in the examination, you mentioned both sides superficial temporal is palpable and equal. So what do you think?
Yes,
Can
sir.
that be there?
As I could not palpate right side carotid artery, sir. So I thought there might be breach in the carotid artery, sir, involvement of the carotid artery. So I wanted to check if superficial temporal artery is palpable, sir.
Yeah, is it
As
equal
it
on
was
both sides?
palpable, sir.
It's
Yes, sir.
equal on both sides?
Yes, sir. It is equal on both sides, sir.
Okay. Can it be equal if there is compression or encasement like this 360-degree encasement?
It will be
It's highly
it
unlikely.
will, if it is more lumen narrowing is more, sir, more than 50%, then it will be less, sir. Not that
Okay.
evidently palpable.
So true cut biopsy you mentioned, core cut needle biopsy. So
Yes,
where
sir.
you want to do and how you want to do? You want to do
Sir,
plain or
USG guided true cut biopsy I want to do, sir. Where
Okay.
the solid lesion is there, sir.
Okay.
As there is areas of necrosis, sir. So I want to take it from the solid lesion, sir.
How many passes you will make? How many biopsy bits you will take?
So 6, sir.
6.
Yes, sir.
Okay. What are the complications you can expect during such a biopsy?
Sir, sir, carotid is near, sir. But we are doing it USG guided, sir, to prevent injury to the carotid, sir.
Even then, there is a high chance of injury
Sense
to
of
the
carotid, yes.
even if you are doing under a USG guidance, there is high chance of injury to the carotid.
Yes.
So you told about lot of IHC markers. Can you just elaborate which marker is for what? For lymphoma, what you will see?
Sir, for lymphoma, I like to see CD45, sir.
Okay. And for
If it is a squamous cell carcinoma, sir, P53 will be present, sir. And CK5 will be present, sir.
and for lung cancer?
So for lung cancer, CK5 and CK7 and 20, sir.
What is TTF? TTF.
Thyroid transcription factor, sir, that is present for both lung and thyroid, sir.
So imagine in the PET scan,
Yes, sir.
along with these findings, there is an uptake in the right testis and right para-aortic nodes. So what you will do?
So chemosensitive, sir, chemotherapy. If para-aortic lymph nodes are there, sir.
No, you don't have a tissue.
Uptake is there in the para-aortic lymph nodes.
No, you have not done a true cut biopsy. FNAC poorly differentiated carcinoma, pan endoscopy
Yes, sir.
negative. You are doing a PET scan. So PET scan shows uptake in the right side testis, right para-aortic nodes, along with the pectoral node and the cervical node, right side cervical node. What is your next level? What is the next investigation of choice?
So it's a testicular malignancy, sir.
Okay.
Suspecting testicular malignancy, sir.
So what you will do? For testicular
Sir,
malignancy, what special investigations you can take in the blood?
Sir, human chorionic gonadotropin, sir, and alpha fetoprotein, sir, to know it is as seminomatous or non-seminomatous, sir.
The tumor markers has to be taken. Okay.
Yes, sir.
So can you get a biopsy now? You want to take
No,
a
sir, we
biopsy?
should not do the biopsy. No, sir.
Why? You don't have a definite biopsy, no? It has come as poorly differentiated tumor. You have a testicular uptake.
Yes, sir.
Can you take a biopsy now?
No, sir, we can't take a biopsy, sir. The skin environment will by doing biopsy will make it extensive, sir, which
So how
causes
can
spread to the scrotal wall, sir.
already it is an M1 disease. So there is no additional spread and all. It's already M1 disease. So what is the safest technique to sample the testicular tissue?
So high inguinal orchiectomy, sir.
Yeah, that can be done. So high inguinal
With inguinal lymph node dissection. Yes, sir.
No. Why inguinal lymph node dissection? Only high inguinal. What is it? The lymphatic drainage of testis. It is into the inguinal lymph nodes.
No, sir, to the para-aortic lymph nodes, sir. Sorry.
Then why do you want to take inguinal lymph nodes?
Yes, sir.
It's
By
just a high
mistake.
inguinal
High
orchiectomy.
inguinal orchiectomy, sir.
You will get a tissue diagnosis. So based on that,
Yes, sir.
what tumor you expect here in this age, 60 years?
Non-seminomatous tumor, sir.
What non-seminomatous? Elderly. Lymphomas are common, okay?
Yes, sir.
Testicular lymphomas.
Testicular lymphoma.
So if it comes as testicular lymphoma, testis remote, para-aortic nodes are there, and the cervical node is there. So what is the treatment now?
Sir, chemoradiation, sir, both. Chemotherapy and radiation, sir. R-CHOPs. They're more chemosensitive, sir.
So they are more chemosensitive. Then why do you want to give radiation? It is chemo or radiation or combined?
Combined chemoradiation, sir.
Which one you will give first?
First chemotherapy, sir.
So after chemotherapy, you will immediately give radiation to the neck and to the para-aortic region?
Yes, sir.
No, it's not needed. So what is the stage now in this case?
M1 stage, sir. Stage 4, sir.
Now if it is lymphoma, what is the staging of lymphoma?
Supradiaphragmatic, sir. Stage 1 involves single lymph node, sir. Stage 2 is involvement of the lymph node above the diaphragm, sir, in the one side of the diaphragm, sir. Stage 3 is on both the sides of the diaphragm, sir. Stage 4 is widespread tumor, sir, with the extranodal.
So what is this here?
Both sides of the diaphragm. Stage 3, sir.
Stage 3, okay, and extra
Yes,
nodal because testis is
Yes.
involved. So what is the
Yes, sir.
treatment choice in stage 3 lymphoma? If it is a non-Hodgkin's lymphoma, it is chemotherapy.
Chemotherapy, yes, sir.
Okay. So what chemotherapy you give? Or CHOP?
Yes, sir. Rituximab, sir.
What is CHOP then? R is rituximab. What is CHOP?
Rituximab, sir. Cyclophosphamide, sir. Oxaliplatin, sir. And paclitaxel, sir.
Oxaliplatin.
Yes.
What is CHOP? CHOP. So P is prednisolone, okay?
Yes, sir.
O is oncovin. Oncovin is vincristine.
Yes.
Okay, then cyclophosphamide and adriamycin.
Yes, sir.
Okay, no, it's not oxaliplatin, okay?
Yes, sir.
R is rituximab. Good.
Yes.
Any other questions, sir?
Dr. Soumya, can you tell me about the types of neck dissections, you know?
Yes, sir. Radical neck dissection, sir. Modified radical neck dissection, sir, and selective neck dissection, sir.
So what are the differences?
Sir, in radical neck dissection, sir, we take out all in internal jugular veins, sir, as a spinal accessory nerve, sir, and sternocleidomastoid, sir. If it is in if we are doing a modified radical neck dissection, sir, we are having types of modified radical neck dissection, sir. That is type 1, sir, where spinal accessory nerve will be preserved, sir. Type 2, sir, where spinal accessory nerve along with internal jugular vein will be preserved, sir. Type 3, sir, where spinal accessory nerve, internal jugular vein, and sternocleidomastoid will be preserved, sir. In selective neck dissection, we have supraomoid neck dissection, sir, and lateral neck dissection, sir, posterolateral neck dissection, sir, and anterior neck dissection, sir.
What are the various skin incisions, you know, for the neck dissections?
Sir, one is McPhee's incision, sir. Another one is Y, sir. And Y incision, sir. Another one is double Y incision, sir.
What is the name of the Y incision?
Uh, uh,
Kryles.
yes, sir. Kryles incision.
Kryles incision. What is double Y? Why there are so many neck incisions for neck dissection? Why not a single? Why so many variations are there? Why do you think? You think an answer.
Because it contains the important structures will be there, sir. Like common carotid artery will be there, sir.
There in all neck. So we can have a
Yes,
single
sir.
type of incision. No, why you have so many different variations?
So for the better exposure, sir,
Yeah, better exposure of what?
of the neck, sir,
No, every
of
neck
the concerned area, sir.
in every neck you need to take the all the nodes, right?
Yes, sir.
So then why so?
What are the complications of neck dissections?
Sir, flap necrosis, sir, seroma formation, sir, carotid artery injury, sir. And if we do the bilateral radical neck dissection, sir, patient will have a raised intracranial pressure, sir.
I think sir got the answer, Ibrahim sir.
Yes. So to avoid these complications, it depends upon where the nodal mass is there, where skin
Yes,
involvement is there, and also how much amount of the primary you are going to resect. For example, if it is a carcinoma tongue, you do a separate incision. If it's an unknown primary, you do a separate incision. And if it is
Yes.
already a post-irradiated neck, you avoid some incisions. Like Kryle's incision are not suitable for post-irradiated neck. Skin necrosis will be common. And 3-point
Yes.
junction we have to avoid. So these are all the some of the points you have to remember. So if it is a post-irradiated neck, McPhee's is better because you won't put any 3-point. And the
Yes.
skin necrosis is less. But neck phase is difficult to operate. You have very less exposure. That's why we have different types of variations in the neck incisions. But you told about neck incision, the neck dissections. These are the structures you preserve, you told. What are the structures we remove? Tell me what are the structures we remove in a modified radical neck dissection?
Sir, we in modified magnetic dissection, sir, we remove the lymph nodes, sir. Level 2, all the lymph nodes we remove, sir.
Okay.
And with that,
Only lymph nodes you have to remove. What else you remove?
sir,
All the structures inside the deep fascia. So you have a neck investing layer, no? All the structures inside the deep fascia,
yes, sir.
except the vein, artery, and nerve. So the vein is
Yes.
IJV, artery is carotids,
Palmated,
nerve is
spinal,
what?
spinal
Spinal.
SSI.
Other than this, all other structures has to be removed. The fat, lymph nodes, lymphatics, all other vascular structures has to be removed.
Yes.
And bilateral neck dissection can be done. Only bilateral radical neck dissection should not be done. When we are doing an IJV ligation, that alone should not be done bilaterally. Otherwise, you can do a bilateral modified radical neck dissection.
Modified radical neck. Understood.
Any other questions?
How do you prevent the carotid blowout when you're doing the neck dissection?
Sir, by placing a tissue over it, sir.
What tissue?
Which tissue you are going to place?
The muscles, sir. The sternocleidomastoid muscles, sir.
So that is
you
there
are removing, isn't?
when we are removing
Sometimes you are removing that sternocleidomastoid.
radical neck dissection. You mentioned,
Yes.
no? SCM is removed. So remove the sternocleidomastoid muscle. So how
Yes,
you are
sir.
going to cover it? What tissue you are going to interpose?
Sir, trapezius, which we can use, sir, as a.
Is that your idea or have anyone done like that? Trapezius? Is there any other muscle?
When you're doing the inguinal block dissection, you cover the femoral vessels by which muscle?
Sartorius.
Sartorius,
Gupta's
sir.
lab.
So
Sartorius.
Yes, sir.
Similarly, you
Similar
have
type of the strap muscle is there in the neck also, Jaina. Which is that strap type of the muscle?
Sir, omoid, sir, sternoid, sir.
No, it is on the back. Levator scapulae is there.
Lever. Yes.
Okay, levator scapulae is the muscle.
omohyoid are very, very small. Okay. So there is
Yes,
a
sir.
muscle called levator scapulae.
Yes,
So
sir.
it elevates the scapula. It is attached in the origin is from the spine of the C2, C3, C4. So you can detach the scapular attachment and bring it anteriorly to cover the carotid. So that's how we have to avoid carotid blowout in radical neck dissection. In modified radical neck dissection, the muscle will be there. The sternocleidomastoid muscle will be there.
Yes.
That need not be worried. If it is removed, you have to cover it. Similarly, you use sartorius muscle in the inguinal block dissection.
Yes.
Then you have to definitely avoid the skin necrosis at that point. And that is why when you use the 3 flaps or 4 flaps surgery which is done, you should always avoid that angulation should not come at that point. Otherwise, that will get necrosed.
Yes.
So that is another reason for a skin necrosis, infection, and the coverage of the carotid vessels.
Yes.
What is the difference between a right neck dissection and the left neck dissection?
What additional structures you get in left side? What is Virchow's node?
So left supraclavicular lymph node, sir.
Why it comes there? Why left? Why not right is coming?
Sir, but because the most common spread to the left sided supraclavicular lymph node, sir, because thoracic duct comes and lands up in the left side, sir. It turns at the T4 level, sir, to the left side and joins the.
So thoracic duct is in the left side.
Yes, sir. Thoracic duct in the left side, sir, at that
It's not
level. Sir.
thoracic duct in the right side. So
Yes, sir.
thoracic injury and lymphoria are common on left side neck
Left
dissections.
side neck tissue. Okay, sir. Understood.
If you damage the spinal accessory nerve, then what happens?
Sir, drooping of the shoulder will be there, sir.
What are the muscles it is supplying? Spinal
Sir,
accessory nerve?
trapezius and sternocleidomastoid muscle, sir.
Okay. Okay.
Can I come in here?
Yeah, Dr. Abhay, please.
Yes, sir.
She seems to be very well read in whatever questions are being asked. I just want to ask her one question. Why this
Yes,
is not a carotid body tumor, rare malignancy? You have not found anything other than on all your investigations.
yes, sir.
Why this is not carotid body malignancy?
Sir, there is no pulsatile, sir. It's not pulsatile, sir.
No, this is carotid body I'm talking about. It
Yes,
need
sir.
not be. It can only give you transmitted pulsations.
Yes, sir. There is no transmitted pulsatile.
This fits into my diagnosis as far as you are concerned. It's
Yes, sir.
encircling the carotid right at
Yes,
the
sir.
bifurcation where the carotid body is supposed to be there. And it's a rare malignancy. It's not that it's very common, but
Yes,
in
sir.
absence of any positive finding elsewhere where these nodes are supposed to be, why this is not carotid body? That's question number one. Question number two is Dr. Khanna asked you a question about sartorius flap. What is the name of that sartorius flap that is given?
Yes, sir. Sir, first, sir, it's not a carotid body tumor, sir, because it's not transmitted. Pulsation is not there, sir.
Okay, go ahead. That's your clinical finding.
Yes, sir.
Have you read about carotid body tumors?
Yes, sir.
So tell me, see, you have been talking so
The
nicely
patient
about,
will be having syncopal attacks also, sir.
but there is engulfment, but no narrowing.
Yes, sir.
Why are you stuck on metastasis?
Because most
You have
common
got
is yes, sir.
you no no 1 minute. You have got a
Yes,
report of poorly differentiated adenocarcinoma, which is a known poorly differentiated carcinoma, which is a known entity
yes, sir.
in carotid body malignant tumors also. All your investigations are not pointing towards any primary. So we are looking for occult primary. You have tried to do that. We have discussed all that. You have answered very well, including questions which should not be asked, according to me, to a general surgery candidate, but you have done well. So now I want you get you into questions which actually should baffle you.
Yes, sir.
So tell me about malignant carotid body tumors.
So malignant carotid body tumors are most common in males, sir. It presents in the elderly
No, no,
age,
no, no,
sir.
no, no. Let's stick to. Don't talk theory. Don't go back to your theory books. Talk
Yes, sir.
practicals. Will you consider this diagnosis or no?
No, sir.
Why?
Sir, based on clinical examination only, sir.
So now you're going back to clinical examination. This
Yes,
is
sir.
a what is the dimension of the tumor?
Sir, 10 cross 10 centimeters, sir, clinically, sir.
Correct.
On
And it is
examination,
in
9 cross.
1 minute. It is
Yes, sir.
involving the sternocleidomastoid as well as I see on your pictures.
Yes, sir.
Yeah. Why it is not a carotid body tumor? Malignant. It's okay.
Over the
Hello?
larynx, sir, and the trachea, sir, and the esophagus, sir. So the patient
No,
will be having more of.
no, no, no. I can make out that you have not read about carotid body tumors, so it's okay. Go back and read about it. The second question was whose uh, with whose name is this sartorius flap to protect the femorals is It's an Indian name.
With the G it starts. Yes, sir.
Pardon?
With the G it starts.
Gupta. I will give it to you. Gupta. It is Gupta.
Yes, sir. With G. Yes,
Yeah,
sir.
Gupta. Okay.
Yes,
So whenever you answer questions in this sort of presentation so well,
yes,
I'm extremely happy that you answered everything so well and that you still remember the names of people who have done good for our society in India. Thank you so much.
yes. Thank you. Thank you so much.
Thank you, Abhay
Dr.
sir.
Abhay has rightly said that this swelling which is there, hard swelling in the
Yes, sir.
carotid triangle here,
Yes,
in
sir.
that area. And it is not necessary that you will get the pulsations in the case of the carotid body tumor. Majority of the time it will not there, Jay. But can you tell
Understood.
what is the mobility of the carotid body tumor? That is the signs
Sir, it will
given
not
for
move
that.
along the carotid artery, sir. It will move in the horizontal plane, sir,
Yes.
but not along
Yes.
the vertical plane, sir.
That is a very important sign in that area if it is there
Yes,
to
sir.
differentiate whether it is a carotid body. But your tumor was absolutely fixed tumor.
Yes, sir. Absolutely fixed, sir. Not mobile, sir.
Fixed tumors, yeah, that's right, yeah. But carotid body tumor should be kept as a differential diagnosis. I do agree,
Yes,
yeah. Dr. Kanaiwal, can we come to the close?
Sir, we have Guru Shantapa sir, the faculty HOD of KMC RSI. Would you like to, Guru Shantapa sir, would you like to give your comments?
Yeah, sir. Good evening, sir.
Good
Kanagavel,
evening,
sir.
sir. Yes, sir.
Sorry, I joined late.
Yes, sir.
Yeah, he has presented well. It was a fixed neck mass. Only thing, the details of the identifying the primary and the management of the neck deposits, other than the surgical treatment. Kanagavel, sir, thank you for the opportunity given to my candidate.
thank you.
Sir, I should thank you for continuously allowing your candidates to come in and go. And
Yes, sir.
thank you for permitting. And this is a very important case. It's not been discussed. Neck has not been discussed for quite some time in our PG clinic. And I
Yes.
think both all the faculty here have covered extensively both benign as well as malignancy in today's discussion. I'm sure with the upcoming exams happening everywhere, this will be a very useful thing, sir. And we will be happy you to join us as faculty sometime whenever it's possible. So I know you are too busy with multiple organizations.
Yes,
You
sir.
have the
Yes, sir.
endoscopy course coming up, and you
Yes,
have
sir.
a lot of responsibilities, one back to back coming up. In between, time permitting, please join, sir.
Sure, sir. Sure, sir. Hope she has made every examiner happy by answering all the questions. I hope so.
Sir, she is a MCH candidate. That's all I can tell. Very
Okay.
simply to tell. Only thing she has to refine here and there a little bit. I hope you took notes, Dr. Soumya, with the faculty where you had
Yes, sir.
challenges in answering.
Yes,
Get
sir.
back to the
Absolutely.
library. There is always avenues to improve. So fill up the knowledge gaps what the faculty have pointed out. And don't stick on to one textbook because reading Davita or reading one particular thing
Yes, sir.
that prefer to be avoided because the head and neck oncology textbook by Justin Patel,
Yes,
Indian
sir.
author but settled down in USA.
Yes, sir.
The
Yes, sir.
Jatin's textbook is a 3-volume textbook on head and neck oncology.
Yes, sir.
The first few chapters are very, very useful. So
Yes, sir.
maybe I hope your library has that because you also have MSc course they should be having. So
Yes, sir.
please go back to read the basics. That's what every examiner is expecting. That is
Yes,
very
sir.
important book. You should spend time on reading it.
Yes,
And
sir.
thank you very much. Sridhar sir, would you like to give your comments, sir, before we call a close?
So she has done very well, sir. Congratulations to her, Soumya.
Yes, sir.
Keep
Thank you,
it
sir.
up.
Yes, thank you.
So thank you very much, all the
No,
faculty. Ibrahim sir.
one minute, Kanagwell. One
Yes,
minute.
sir, please, sir.
This candidate is surgical oncology candidate, and the
No, no.
examiners are no. I'm just trying to tell
Okay,
you,
okay,
and
okay.
the examiners are surgical oncology teachers.
Yes, sir.
And she has actually waded through them. That's why I kept on listening and kept on, try to divert her and get her into a situation where she doesn't know what is happening. She knew every examiner is going to bombard her with dose of anti-malignancy drugs, which is not expected at PG level at MS general surgery. But she navigated very well through all this. Congratulations to her. And if Guru Shantappa is the teacher, I salute him for doing this wonderful job. Keep on doing these sort of jobs for reason that they know exactly what the examiners are going to ask him or ask her, and do well.
That
I'm little senior to these people, so I can come in with a lateral thinking and get them into trouble, because one sided thinking can get a person who's appearing for PG into a lot of problems. I'm not one of them.
Yes.
I'm very clear. This girl has to not only pass, but pass with distinction for sure. I can have comments from the other people who are surgical oncologists. Thank you so much.
Sir,
Thank you. Thank you so much.
Dalvi sir, I would like to thank you so much. She is in my unit and she is my student. I am her guide for dissertation. She is a very sincere girl and she has lot of interest in improving and learning, sir. Thank you so much for appreciating her efforts, sir. Dalvi sir.
Thank you. Thank you, sir.
Very well done, Soumya. Very well
Ibrahim
done.
sir and Kanna sir and Ibrahim sir, any comments, sir? Can we call a close?
No, just very well done. Yeah.
Yes, sir. Thank you, sir. Thank
Soumya,
you.
very well done. Yeah, yeah.
Yes,
Thank you.
Soumya, you did very well. And this neck node appears very, very simple, but the discussion can go anywhere.
Yes, sir.
It can go from carotid body, melanoma, anywhere. So you
Yes,
have to
sir.
be prepared. And if you are more shrewd, you can take the examiner where you want to take him or her. So that's the idea. Okay. And
Yes,
be
sir.
confident in answering everything. And all the
Yes,
best.
sir.
You did well today. All the best for your exam.
Yes. Thank you, sir. Thank you so much.
So thank you everyone. And
Thank you.
on behalf of the PG clinics, we wish all the postgraduates for all the best, because many centers are running the exams, have just finished the exams. I think National Board has announced the theory exam dates in the month of June, and many universities have finished the clinical part of it, and few are running the clinical part of it. Good luck to all the exam going PGs, and more so from the faculty of PG clinics. All of you do the exams, NEET SS very well, and I hope all of you are preparing well.
Yes, sir.
Multiple centers have been allotted and 2 different sessions are planned. So all of you reach the exam centers minimum 2 to 3 hours in advance, because it's a online based exam. So good luck to all of you who are appearing for the NEET SS tomorrow and day after. Thank you very much. And with the permission of the faculty, we call this session a close. Good night, everyone. Thank you all
Thank
faculty
you.
for contributing your valuable time and wisdom for this program. Thank you, Guru Shantappa sir, for
Yes,
permitting
sir.
your
Thank you, sir.
postgraduate.
Thank you, sir. Good night, sir.
Thank
Thank
you,
you.
sir. Thank you very much.
Thank you,
Thank
sir.
you.
Thank you. Thank you.